So now we'll continue with talking about kinematics and dividing it up into two different sections. There are osteokinematics and arthrokinematics. In terms of osteokinematics, sometimes we call this physiological movement. This is the motion or the movement that is under our volitional control. And when you hear volitional, you probably think voluntary control. Movement that I can actively do. I can move my shoulder over my head, so I can do shoulder flexion, shoulder abduction. So when you hear osteokinematic, thinking about the motions that I can do or I can ask a patient to do. Can you straighten your knee? Can you bend your knee? Can you do knee flexion? Can you do knee extension? Those are your osteokinematic or physiological movements. This is different than arthrokinematic. When you think arthro, you think of joint motions, and in particular, you're thinking about joint surface motions. So the articulating surfaces between two joints, how do they move? How does one move on the other, or maybe both of them are moving simultaneously on each other? Sometimes you have a fixed bone, and sometimes you have a dynamic bone. Sometimes you have two dynamic bones moving. These are also referred to as accessory motions or joint play motions. So that's another term to know, joint play. So to summarize, we have joint surface motions, and these are called joint play motions. Another question is, how do we measure each of these? So what are the different tools or measurement techniques to measure these? With osteokinematic motion, we use measurement via goniometric measurement, range of motion, an inclinometer, or a goniometer typically. So that is how we measure osteokinematic motions. With arthrokinematic motions, because the joint surfaces are under the surface and we can't directly see how the surfaces are moving, we use our accessory motion glides by manipulating and mobilizing the joints in different directions. So that's our joint play assessment. So range of motion, goniometric, inclinometer, or joint play assessment is the way that these are measured. As we talk about arthrokinematic motions, we're talking about one surface on another surface. So for this, I want you to look at the green bowling ball, and I want you to look for 3 different motions that the ball is going to be performing. We're going to look at how the ball rolls, how the ball glides, and how the ball spins as it is done here in slow motion on a very greased, oiled, well lubricated lane to allow for very little friction. If we change the friction with this, you would notice more rolling and less gliding and less spinning. But obviously the oils add to the spinning and the gliding or sliding. So look at this. So you can see as the ball comes in, it's not just rolling, it's gliding, it's sliding along the top surface of the lane. And then as it hits the pins, it's now spinning differently. The force is being altered in terms of the direction and the position. It's a little hard to see everything on this viewpoint. So we're going to go to a bowling ball on cornstarch. So similar thing, and you're going to pay particular attention to when it first hits the cornstarch.
Once again, time warp cameras capture the extraordinary. A 12-pound bowling ball glides as if on solid wood. Then the other side of a split personality emerges and submerges.
So with that, you could see there's even a lower friction initially, but then the friction becomes much higher with the cornstarch. So when it hits the cornstarch, there's a lot of gliding, but there's not as much rolling. So those are the three motions that our joint surfaces do all the time. And we'll apply that to some arthrokinematic motions here. So let's talk about these one at a time. So first there is the rolling motion. With the rolling motion, you're looking how one joint surface moves on the other joint surface. And in particular, I like to think of it as how does the shaft or the extension of the bone, it could be proximal or distal depending on the joint that you're referring to, but how does that shaft move on there? So if we look at this, so someone is standing initially right here, and they start to bend their knees. They start to squat down or lower themselves down. You could see that initially this part of the femur was contacting this part of the tibia. But as they flex, the femur goes posterior. The tibia stays static, but the femur goes posterior, so it's a posterior roll. And now this part of the femur that was in contact with the tibia is now no longer in contact. So that's your example of a posterior roll. Some people would describe this as an angular motion. So if you're looking at a physics or biomechanical term, this is angular movement. Now compare and contrast that with a glide or a slide, and those terms we're going to use interchangeably. So glide or slide are going to be used interchangeably. This is a linear or parallel movement of one joint surface on the other. So this is the femur sliding or gliding on the top surface of the tibia. You still get a change in position. So now this part, the posterior aspect of the tibia, was in contact, but now the anterior part of the tibia is in contact. And I will say this, if you look at this image, I think this image is good in trying to teach you the concept, but it's completely exaggerated. Whenever you're performing knee flexion, you're not going to have that much gliding or translation of the femur on the tibia. Your ACL and PCL and other ligaments would completely restrict that. So this is not a realistic image, it's more of a conceptual image, but there's no way you're going to get that much gliding with intact ligaments. There would be other issues going on if you had that much joint motion there. But you can see that the glide is starting here and it's going in this direction. So we're going to say this is an anterior glide of the femur, or sometimes refer this to the relativeness, which means it's a posterior glide of the tibia on the femur, depending on whether you're open or a closed kinematic chain. So these are linear motions. The glides and slides are linear, and the rolls are angular motions. And then there's a third one, which is the spinning motion. So if you look here, this is a good example of spinning. So if you look at the forearm and you're looking at how the ulna here is going to be your fixed point, whereas your radius is going to roll on top of the ulnar. So this is the proximal radioulnar joint. And so if you look at that, it's a relatively fixed movement, and you're just getting what I describe as a pivoting, but it's a spinning. It's a rotation around the center axis. So the axis in this point does not change. It's a fixed axis. Whereas on the other picture, when I showed you at the knee, there is some movement. So with this, you can see there's not that gliding forward. And this representation is more accurate of how the tibiofemoral joint actually looks with knee flexion. It's more of a spin. But there is a glide component to it as well. So ultimately, we're getting all three of those motions with our normal joint motions. With our normal osteokinematic motions, we're getting all three things happening at once. Now, depending on the joint and depending on the motion and depending on what is going on pathologically with your individual, you may get more or less of these motions. So someone may glide more than they spin, or someone may do more of a roll because they're missing a glide, or things like that may occur. So we can do motions to that. But I do think this is an important point here. Good, good. So let's talk about the spin a little bit more, because while the spin is important, we really don't focus on the spin significantly. And I really am not going to ask you how a joint is spinning on a quiz or an exam. It's important to understand this concept, but I want to show you why we don't, as physical therapists and physical therapist assistants and athletic trainers and chiropractors, focus on the spin as a technique or describe it as a spin, even though biomechanically it is actually a spin. So here's a little clinical example. Let me show this video. So this is a proximal RU joint mobilization.
Okay, so now we will be so have the patient place his or her forearm on the plinth, and you want the elbow at about 70 degrees of flexion and 35 degrees of supination. This is the resting position of the proximal radial ulnar joint. So with one hand, you're going to stabilize the ulna.
Stabilize the ulna.
On the other hand, you are going to mobilize the radius. So, with your left hand, palpate for the radius. And you will be pulling in an anterior direction for restricted supination. We'll push in a posterior direction for restricted pronation. So this is opposite of the distal radial ulnar joint due to the convex concave rule at the proximal radial ulnar joint.
So with this, pronation and supination, if you had a patient that was limited with pronation, there's an issue with the spinning of this radius on the ulna. And if there's a difficulty with spinning, we want to promote that by trying to spin this joint. But as you could see when he was performing that, it's really hard to, with your hands, grab someone's radius and spin it. So instead of doing that, in order to simulate this spinning motion, the best way we can do this is by providing a posterior glide. So doing a translation or a linear movement to help restore a rotary movement or a spinning movement. So clinically, if you think about the bones and their positions, we can really only manipulate them and mobilize them in our hands the way that they can go, and that we often can't spin joints because we can't grab a joint effectively and rotate it around its fixed axis. So for that reason, we don't really focus on the spins. We know about them, but we try and go around them by doing what we can with our hands and doing that from an anterior, posterior, or medial lateral direction. So this all goes back to the convex concave rule, which you heard I mention in the video. So I'll display this really quickly to show you that joint surfaces generally are concave, or if you put your hands together like a bowl of soup or water, that is concave versus convex. There are some surfaces that we know that are relatively flat. So if you're thinking about more planar joints, if you're thinking about the intercarpal joints or the midfoot joints, there's a lot of really minor concavities or convexities to them, but they're relatively flat in shape. But for most prominent joints, there is either a convexity or a concavity to them. So here's the basic rule. And it really comes in two variations. If a convex surface moves on a concave surface, it glides in the opposite direction. Whereas if a concave surface, like the tibia, moves on a convex surface, like the femur, it glides in the same direction. And there's certainly a quick video that you can watch about this, and this was posted in Canvas if you want to check out that video. I do want to point out that there is a slight textbook error here. The words are correct, but the image, the words on the description are correct, but this part of the image is this. So with this, you could see A is correct. You have a moving convex on a concave. So a convex on a concave. But in this case, you have a moving concave on a convex. So it should be a concave on a convex. So an example here is shoulder flexion. Humeral head is convex. Glenoid fossa is concave. Therefore, you have a convex moving on a concave, and so that is going to be opposite. Whereas with knee flexion, the tibia and tibial plateau is concave. It's actually more concave because of the meniscus as well, if it's intact and appropriately healthy. And the femoral condyles are convex. So therefore, this would glide and roll into the same direction. Now, not to be confused with this, but if you look at the first CMC joint, you notice that there's convex and concave ends. It's not quite exactly like this, but this is a nice conceptual representation how, depending on which portion of the joint surfaces you're dealing with, whether it's abduction or flexion and extension of the thumb, there's a convexity or concavity to it. And then as you look at the tibiofemoral joint, there would be a difference whether it's the femur moving on the tibia or the tibia moving on the femur, which happens with dynamic or closed kinematic chain motions. But even if someone does a squat from a standing position, you will find that the tibia and the femur are both moving. So it's not necessarily only one moving on a fixed other one. There's two dynamic bones that are simultaneously moving in different directions. So we will go over that some more, but don't get too confused with this. Just stick with the basic convex concave rule on the previous slides. And then finally, there's open and closed kinematic chains. So even though this does deal with kinematics, we're looking at, is the distal end of the extremity fixed or is it moving? So here's your basic summary, and this is even on the front of the textbook. So on the left image here, if we're looking at right knee flexion, and the individual is standing, the foot is moving. So as he bends and straightens his knees, the foot is moving in free space. It's not contacting the ground or any equipment or anything else like that. It's completely free to move around however it would like. So this is going to be considered open kinematic chain. And this typically is going to occur in a non-weight bearing condition. So open kinematic chain, there's no weight going through the lower extremity from the ground. So if you want to look at A, you could say there's no ground reaction force with the right lower extremity. Consequently, we know the left lower extremity has doubled the amount of ground reaction force because now his whole body weight is being transferred to his left foot. Instead of when he's standing on both feet, half the ground reaction force is going to the left, half is going to the right, assuming that he's standing evenly. Maybe it's 52-48, maybe it's 51-49, but it should be relatively even between right and left foot if he's standing in a static neutral position. But on the right-hand side, in letter B, what are we looking at here? We're looking at multiple joints here. We're looking at closed kinematic chain. So the difference here is that because the foot is fixed, the distal segment is fixed. Distal segment is fixed with that, and it is a weight-bearing condition. This force is going to allow other forces to be transmitted throughout the whole kinematic chain. So as you squat forward, and even if he did this on one leg, he has to perform ankle dorsiflexion there, he has to perform knee flexion there, he has to perform hip flexion there. Whereas in this open chain scenario, or open kinematic chain, he can flex the knee independently, and the hip doesn't have to change position. the ankle doesn't have to change position. So for that reason, it's much simpler to perform open chain exercises in the beginning. They're more isolated, independent movements, and it doesn't involve joint compression, compression of the articular surfaces, the menisci, if there is a meniscus at that joint, the hyaline cartilage, ligamentous compression, other things like that that occur. Whereas closed chain is a nice way to progress a patient, and often we think of closed chain exercises as more functional because open chain can sometimes be considered less functional because you don't have to really do this. That's not a motion you typically perform as part of your ADLs, whereas this is a common motion that you perform with your ADLs. So there's more example of open and closed kinematic chain, and there's some variations on this, but I think these two definitions will be well served for open and closed kinematic chain, and definitely look at the book in more detail about this, but that's the basic information about open and closed kinematic chain. That being said, we don't want to confuse open and closed kinematic chain with open and closed packed position. This has to do with the joint surface and the ligamentous restraints and joint congruency on there. So in an open packed, sometimes called a loose packed position, this is where you have maximal incongruency. So where the joint surfaces are not at a good fit. So if you think about a key going in through a lock, the key would not be able to turn the lock because there's incongruency. Whereas a closed pack position, this is the position of maximal congruency. So if you have two surfaces, they fit really well, like a lock and a key, they really fit well with each other. This will be a closed pack position. Typically in this position, the capsule and ligaments are taut, and this might occur at one extreme of the range of motion. And sometimes this is also known, closed pack is also called the locked position. And this is going to vary by joint. We'll get you a joint list of the peripheral joints and show you the open and closed packed positions for that. This also ties into the stability of the joint. So in an open pack position, the joint has less stability. In a closed pack position, the joint has more stability. So you want to also tie that concept in there. So there we go. So let's talk about how do we assess these joints with our hands and look at how they're moving. A lot of this came from James Syriacs, who was a physician out of England earlier in the 1900s, and then Freddie Kaltenborn, who just recently passed away, and he also brought a lot of different dynamic assessments for joint assessments. With this, there are three main types of endfields, and you can look at page 56 in the textbook for this and more definitions. But we can go over some different endfields and how these are set up. So I'd like you to look at the book and look at these different endfields and work through the examples of those different endfields for this portion. And then I do want to mention that there is considerable variability in the nomenclature and the terminology that we use for these endfields, but to use the three main ones of hard endfield, soft endfield, or firm endfield is generally going to be represented well. This will be covered more in Clinical Assessment 1. And then in terms of abnormal endfields, ones that typically aren't associated with a joint, there could be an early endfield. So if I go to strain my elbow, I'm expecting a hard endfield into elbow extension, but if I don't get to end range extension, I may guard and have an early endfield. So the patient may abnormally stop the joint from moving, and so that would be considered an abnormal early endfield. It could be associated with guarding or inhibition of moving the joint due to pain or other pathology. There's also an absent endfield. So even though there should be a point where the elbow extends and it keeps extending until the ulna and the humerus lock out and have that hard bony endfield, if it keeps going, there may be some type of fracture or other pathology there. This can happen at the knee. If the knee keeps extending, you expect the caps on the ligaments to keep that from fully extending, and if it just keeps continuing to extend, there could be that absent end field. So that's also a pathological end field associated with some type of tissue pathology. Could be a fracture, could be a ligamentous rupture, tendon rupture, other things like that could cause these abnormal end fields. And then, what is the term for a shortening of soft tissue structures around the joint with accompanying fibrotic changes? I'll let you look that up in the textbook and answer this question. And then there are accessory motions. These are 3 forces that are used during the joint play assessment or the joint assessment or the mobilization session, and mobilization referring to the same joint play activities but just doing these repetitively as a treatment approach. There is traction, or separating the joint surfaces apart from one another. There's approximation, or compressing the joint surfaces together, and there's also this shear force, or the gliding force. So we can use all 3 of these to determine how well or not so well a joint surface is moving on another joint surface. And then with that movement, this is something to be done more in MSK1. As you do these movements, and this is primarily translatory movements, as you do those movements, there is the Kaltenborn scale of 0 to 6. Other people use just a more simple 3-item scale. Is something hypomobile, which means it's not moving enough? Is something normal, which means it's moving appropriate amount for that joint? Or is it hypermobile? So someone with generalized ligamentous laxity might be hypermobile at multiple joints. So we can compare this to what we think it should be for that particular joint. We also can compare this to the other extremity to see how much that other one is moving in comparison. So right versus left, side by side,